and then discussion will start. So I give you a scenario. You got a card, and that a 65 years old gentleman presented to OPD with complaint of black discoloration of his right great toe for last 15 days. That is
Okay,
a
sir.
card saying that patient has got black discoloration in his great toe. Patient is 65-year-old gentleman. So how do you proceed? So once you have a card like this, easily discussion starts like that. Uh, you need to do a good evaluation of the patient, do some relevant investigations, and then come to a diagnosis and some discussion on treatment of this patient. So,
Nishi, somebody
Shani,
join the
if
I'll be chapel.
Dr. Das has joined, not yet. Okay. So, if you have a patient like this, what are the
Good
possibilities
morning,
of
Vasanta. I have
good?
joined.
Okay. Good morning. So, if you have a patient who has got such presentation in the OPD, so what is your uh, uh, thought process that what might be the important causes of such black discoloration? Just first think of the probable causes, and then we'll discuss how do you proceed with this patient. What are the important causes?
Sir, one can be diabetic, so that changed into gangrenous changes.
So one can be diabetes mellitus leading to gangrene. Yes, diabetic patient may have
Yes.
gangrene. What are the more common causes? Diabetes is definitely a different cause, but a 65-year-old gentleman presenting with gradual onset of black discoloration, some more uh,
Sir,
peripheral
any
vascular.
peripheral arterial disease can be there.
Yes, which arterial disease we think is more probable in a patient like this?
Sir, Barger's disease can be there.
No, you see, 65-year-old gentleman, we should not say Barger as a first cause of such patient.
Okay,
Barger,
sir.
we'll discuss some amount of Barger because Barger has become very rare nowadays. So we should
Okay.
not say Barger as the first diagnosis. 65-year gentleman, the first diagnosis should be atherosclerotic peripheral vascular
After
disease.
research. Okay,
Okay.
sir. Okay.
So, elderly patient has more incidence of atherosclerotic vascular disease rather than Barger's disease. So,
Okay, sir.
Barger disease has got definite criteria for diagnosis. We'll come to that. So, what else can be the diagnosis? If I have said that 15 days duration, I have not told about the onset of gangrene. The onset of gangrene may be sudden. Maybe that 15 days back, the gangrene has started suddenly over a period of hours or maybe one day. So, elderly gentleman presenting with sudden onset of gangrene may be due to what?
Sir,
Sudden onset of
is there
gangrene?
can be any embolus in the peripheral
Yes, yes. So, the next
and
important
that
cause
has
is
compromised
embolic
the blood
gangrene.
supply? Okay,
Embolic
sir.
gangrene. Okay.
Yes.
So, peripheral vascular disease due to atherosclerosis, embolic gangrene. What other peripheral vascular disease may affect a patient? You want to say it is diabetes mellitus. So,
Yes, sir.
diabetes mellitus can cause gangrene either by angiopathy or by infection.
Yes.
Okay.
Yes, sir.
So, as I said, a 65-year-old gentleman will not bring the possibility of Barger's disease. Why?
Okay, sir.
Do you know what are the uh, now rarely see Barger disease is a very common disease happening in smokers, but
Yes, sir.
nowadays we find very rare instances of Barger's disease. So, if you want to say Barger's disease, what are the criteria for diagnosis of Barger's disease?
Sorry,
Barger
sir,
disease
I
has got
haven't
some
studied it.
characteristics. Yes.
Sorry, sir. Recently, I haven't studied. I have forgotten the criteria.
So, Barger's disease usually happens in young adults. in the age group of
Okay.
20 to 30 years, number one.
Okay.
Number
Okay,
two,
sir.
this happens only in smokers.
Okay, sir.
Buerger's disease affect the medium and small size vessels.
Yes, sir.
And Buerger's disease may be associated with Raynaud's phenomenon, may be associated with thrombophlebitis. That means apart from the arteries, the veins also can get involved in Buerger's disease.
Okay, sir.
So these are the important criteria. It does not affect the big vessels like femoral or iliacs.
Okay, sir.
So if you think that this patient has got a peripheral arterial disease, what are the steps? I have given you only one line saying that black discoloration. So to come to a proper diagnosis, what are the important uh, assessment in history and what you look for an examination in this patient?
So we'll start from history taking,
Yes.
or okay, sir. So first of all, the duration is 15 days. Then we'll ask if there was any history of trauma or any thermal injury was there or not. If we think it can be in the line of diabetic foot, then we'll take the history of any trauma or thermal injury was there or not. And since how many days these are present, these are intermittently present or uh, it's a continuously present. Previously it was present or it just has started 15 days back. Then we'll look for inspect for any kind of ask the
So this
patient if
question
there
is
is.
after no. There are some more things in history that needs to be uh, elaborated in this patient. We give a first diagnosis of atherosclerotic peripheral vascular disease. So,
Yes,
if
sir.
in a patient of atherosclerotic peripheral vascular disease, now the patient has come with gangrene. When the atherosclerotic disease starts, there is gradual narrowing of these vessels.
Yes, sir. There can
So,
be
what may be
pain.
what before the gangrene sets in, what may be the other symptoms patient may have in the preceding time?
So, is there any pain or not? We have to ask
Yes.
the patient.
So patient with atherosclerotic vascular disease may present with intermittent claudication. And this
Yes,
claudication will depend. Site, you see, claudication may happen in the foot, can happen in the
yes,
cuff, can happen in the thigh, can happen in the buttock. So all these will depend on the site of the disease.
আমি বয়স হচ্ছে আমার
yes,
Dr. Boshak, mute,
হ্যাঁ
mute,
হ্যাঁ
please. So, so, so this claudication pain will depend on the site of the block. So this claudication is a classic claudication that patient is having pain when he starts walking. And
yes,
initially patient can walk for some distance and then the claudication may aggravate.
okay.
And if this disease progresses further, this will lead to what? This pain will change to rest pain.
Yes, pain.
Okay. So you find this patient has got history of claudication and then he was having wrist pain, and then following a minor trauma, he noticed that this right grade to become black. So that
Yes,
gives a classic sequence that this is most likely a peripheral vascular disease which is gradually getting narrowed and then gone to a critical stage of gangrene.
yes,
And once you think that a patient has got a peripheral vascular atherosclerosis, atherosclerosis is not a localized disease.
yes, sir.
Patient with atherosclerosis may have generalized disease. That
Yes,
means
sir.
we should inquire whether the patient has got claudication in the opposite
Chest pain or
chest,
not?
any claudication in the upper limbs. This
Yes,
patient may have associated coronary artery disease.
yes, sir.
So, in the history, we should inquire all these to exclude whether this patient has got a associated coronary artery disease or not.
Yes,
And then if it is the embolic disease, if we think that this might be because of an embolus coming from the heart or from the
yes,
peripheral sides, so what this patient may have? The patient with uh, heart disease, patient with ischemic heart disease or patient with a valvular heart disease
Yes.
has higher incidence of uh, embolic gangrene. So we should inquire whether the patient has got any breathlessness, any chest pain.
Yes. Breathlessness, chest pain is there in me.
Okay.
Yes.
And then comes a patient may have this gangrene may also occur due to small vessel disease in the distal toes. These are described as vasculitis.
Yes.
Okay, so
Okay.
patient who has got vasculitis may have associated other diseases like
Sir, is there can be any retinopathy or nephropathy like changes?
yes, that may be there.
Mm.
But what I'm trying to say is, patient with vasculitis may have other autoimmune diseases like arthritis,
Okay.
rheumatoid arthritis.
Okay.
And then if the patient has got diabetes, a detailed history of diabetes, the duration of diabetes, whether the diabetes is controlled or not.
Okay.
And if you think this is an infective gangrene, then patient
Yes,
will
sir.
have pain in the foot, there may be swelling in
Mm.
the foot, patient may have
Yes, sir.
fever. So these are the important history points one should inquire from the patient.
Yes.
So now you're going to examine the patient. So what
Okay,
you
sir.
ascertain in examination to come to a diagnosis clinically, and then we'll plan for the investigation.
Okay, sir. Sir, at first we have to look for the attitude and any if any, there is any deformity of the limb or not. There is
Now,
any swelling or
first
not.
is general. Don't forget that any sequence examination. First will be general examination.
Yes, general
Okay, we'll
examination.
do a general examination. Assess his
Yes.
vitals.
Yes,
Look
sir.
for any toxemia.
Yes, sir.
Okay. So assess
Yes.
his general examination, and
Yes,
then
sir.
come to the local examination.
Local
So
examination.
what do you examine in the lower limbs to
Yes, sir.
assess for peripheral vascular disease?
Sir, how the attitude of the limb is, or is there any deformity? There is any swelling is there or not? Edema is there or not?
Yes.
Uh, then, sir, as it, the extent of the blackish discoloration,
Yes. So
site.
so the heading should be. You said the first heading of the examination is attitude and deformity of the limb. This patient, you
Yes.
already said he has got black discoloration of the right great toe.
Yes.
So you look at the attitude, patient will be standing and look at the
Yes.
attitude of the limb. What is the
Yes.
normal attitude of the limb if you go by the ankle, knee, hip? What is the normal when the patient is standing in front of you? What is the normal attitude of the patient? Ankle should be ankle should be 90 degree,
Okay, sir.
knee straight, hip straight.
Okay.
So when the
Okay.
patient is standing, there
Yes.
should not be any flexion in the knees,
Yes.
okay, or any flexion or any deformity in the hip also. So patient can
Okay.
stand with the leg side by side.
Yes.
Deformity means as the patient is having some ischemic changes, patient may have
Yes.
some deformity, patient might have lost other toes previously. Okay, so
Yes.
as the patient
Yes.
is standing, look for any deformity.
Yes.
Then heading will be look for signs of peripheral ischemia. And in that
Yes.
case, you should compare the opposite limb to this limb.
Yes.
So once you look for peripheral ischemia in the limbs, what do you think are the signs of peripheral ischemia? Keep in mind that once the patient has got a black discoloration of the toes, that is the end point. So the most important sign of ischemia is the black discoloration of the gangrene. Apart from gangrene, patient may have some other features of ischemia, like
And erythema can be there. Edema, loss of peripheral pulses.
no, pulses will be by palpation.
In
But when you
examination,
look at this
palpation.
patient, there are some signs of peripheral ischemia which you can look out by inspection. Number one is the skin.
Skin changes, sir.
There are skin changes, hairs in the skin,
Mm.
hairs in the skin. Then nails.
Brittle
Normal,
nails.
normal nails are pink.
Yes,
You can look at the nails. The nail become brittle.
that brittle.
The skin may become shiny or black.
Yes, sir.
And then you can find ulcer or gangrene.
Yes, yes.
So if you find a gangrene, what are the things you should look for at the gangrenous site? What are the examination for a black area? What you look for?
First of all, we look for the extent of the gangrene, how much it has extended.
Extent of the gangrene is one. Next is the gangrene may be dry gangrene or it can
Yes,
be wet gangrene.
wet gangrene.
So dry gangrene means there is gradual narrowing of the vessels
Yes,
and the particular toe become dried and shriveled up.
yes, sir.
In wet gangrene, this area becomes swollen. There may be
Yes,
active discharge.
yes.
So try to differentiate on inspection whether the gangrene is dry or gangrene is
Dry
moist,
gangrene. Good. Yes,
and whether this gangrene has got a definite line of demarcation.
yes,
Okay, so the gangrenous area may become clearly demarcated from the normal healthy skin,
yes,
and you can make out the depth of gangrene. Sometimes gangrene can involve only the skin thickness, or gangrene can
yes,
involve the whole toes, deep up to
yes,
the bone.
yes,
So, extent of the gangrene is dry or moist gangrene, whether
yes,
there is a clear demarcation between the gangrenous area and the normal area,
yes,
and look for the adjacent area close to the gangrene. So,
yes,
adjacent area may appear edematous. Okay, so once you have looked for the signs of peripheral ischemia, now you look for some other points in the legs. So, patient who has got chronic ischemia and who has got a claudication earlier may have wasting of the muscles.
yes,
So, look for muscle wasting. On
yes.
inspection, also you can make out whether there is any muscle wasting or not.
Muscle wasting.
Then, what
So
else?
there can be any joint deformity.
Yes, yes. Another
Claw foot
important thing
can
to
be
look
there.
for in the leg is you look at the veins. You see, the
Okay.
lower limb has got veins.
Yes.
Any ischemic limb, what do you think? The veins will be seen normally filled up veins, or you'll find the veins will be empty?
Well, veins will be empty.
Yes. If you find that you can see the normally distended veins in the leg, that indicate that blood supply should be adequate. But patient who
Yes.
has got peripheral ischemia, the
Yes.
veins may appear empty. The veins may not be seen full.
Yes.
Okay. Then what you ascertain by palpation? When you go for palpation, you should palpate and make out some points to come to a diagnosis that what is the likely cause of gangrene in this patient.
Yes. We'll look for the peripheral pulses are present or not. Which peripheral pulses is
The
absent.
pulses will be examined
Mm.
at the end, but there are some role for palpating the gangrenous area also. So once you palpate the gangrenous area, normally the gangrenous area is anesthetic. It is dead.
Yes. No sensation will be
And
there.
by palpation, you can make out whether this gangrenous area is dry or not. As
Dry
I
or
said,
not.
the gangrenous area, if it is dry, it will be dry, shriveled up.
Yes.
In moist gangrene, it will be swollen,
Wait.
may
And
discharge
swelling.
pus or may
Yes.
discharge some cerebral discharge.
Yes.
and then you have to palpate the area adjacent to the gangrene. The area
Yes.
adjacent to the gangrene may be hyperesthetic, may be tender.
Yes.
And then you can confirm by palpation the degree of muscle wasting.
Okay.
I said on inspection you can make out the muscle wasting,
Muscle wasting.
but incipient muscle wasting has to be ascertained by measuring the circumference of the cuff area or the thigh area.
Okay.
Then you have to do a palpation of the pulses of the limbs as well as the central pulses. As I said, if the patient is atherosclerotic, patient may have disease involving the cerebrovascular vessels also. Carotid may get the disease.
Yes.
So make a chart of the peripheral pulses. And then the systemic examination. Now, at the end of your clinical diagnosis and examination, you feel that this gangrene might be because of uh, atherosclerotic peripheral vascular disease. So, what should be your uh, approach for this patient?
Some relevant investigations have to be done for this patient.
Yes. What?
In case of blood reports, we'll do we can do lipid profile.
Yes. So, patient with
Then
atherosclerotic vascular disease may have lipid abnormalities. So, in that case, you have to treat this patient with the appropriate drugs. Lipid profile, yes. What else? Before that, you should do a hemogram also, because these patients
hemogram
who are
and
infected,
yes,
patient
sir.
who may have evidence of infection will have high leukocyte count. If
Yes,
high
sir.
leukocyte
TLC,
count
DLC.
is high, patient will need antibiotics.
Yes, sir.
So, total leukocyte count, you should assess for anemia,
Yes, sir.
you assess the patient blood sugar. So, if he is
Yes, sir.
diabetic, you need to control his diabetes.
Yes.
This patient may have associated renal disease. So, you should
Yes.
find his urea and creatinine. So,
Urea creatinine.
all the routine investigations are not routine here. These investigations are very relevant in a patient who has got a peripheral vascular disease presenting with gangrene.
Yes.
So all these are very important investigation and should not be termed as routine. These are all relevant investigation in this patient. So once you have done this baseline investigation, you also should do a chest X-ray and ECG and echocardiography.
ECG and echocardiography.
So how do you assess the peripheral vessels? What examination is required to assess the peripheral vessels?
The imaging modalities you are asking?
Yes, yes.
Sir, we can do Doppler study.
So it is described as a duplex study.
Duplex
Okay.
study. So,
Yes.
yes.
So it's a duplex study, which is a combination of a B-mode ultrasonography and you
Yes.
apply Doppler principle on that.
Yes.
So what are the things, once you do a duplex study, what are the things you look for in assessment of the peripheral arterial disease? So what they assess, if you see a report of duplex study, you will find the radiologist mentioned some important points like.
Yes, sir. The flow is monophasic or biphasic or triphasic dimension.
So you see, there are a lot of things in this study. Okay, a lot of things. You can do a number of observation while doing this Doppler study. So once you do a B-mode ultrasonography, the
Yes.
the vessels are running side by side. You have the arteries, you have the vein close by.
Okay.
So once you do B-mode ultrasonography, you identify the artery and the vein.
Yes.
And your job now will be apply the Doppler on the arteries.
Yes.
So if you apply the Doppler principle over the arteries starting from the femoral and then go down all the labels. What are the different informations you can get by doing this duplex study? Number one is the radiologist can listen to some audible signals. Okay.
Yes.
They use a headphone and apply the Doppler probe over the arteries.
Okay.
What are the different audible signals you can hear by applying the Doppler probe over the arteries? What is the normal sound you listen? Once you place your stethoscope on the heart, you listen to what?
An audible S1 and S2.
You listen to lab dub.
Loved it.
So once you place the Doppler probe over the peripheral arteries, what normal sound you hear? It will be again lab dub, because this
Okay, sir.
heart sound is transmitted to the peripheral vessels.
Perfect.
And
Okay, sir.
Doppler probe is a very sensitive probe, so you can have the normal audible signals over the arteries. What abnormalities may appear in a patient who has got a atherosclerotic peripheral vascular disease?
Sir,
What is
there
going to
can
happen?
be any absent
Before absent,
sound.
if there is a narrowing, what,
Yes, sir.
please,
It will
please,
be.
Konaklata, please mute. You are Dr. Konaklata. Dr. Konaklata, please mute. Oh, Dr. Konaklata, can you hear us? Please mute yourself. Yes. So once you place the Doppler probe and if you find that the artery is narrowed, what
The
happens to the
sound
narrowed
will
artery?
decrease first.
Initially, there will be rumbling sound.
Okay, sir.
This labdub will be replaced by murmur or rumbling sound.
Okay, sir. 1 minute.
And if there is a complete occlusion, you will not able to listen to any sound.
Yeah,
So
okay.
first thing to ascertain from this is the audible signals about the vessels. Number one. Number two, you try to say the monophasic, triphasic, biphasic. Once you place the probe over the artery, you can trace the pulse wave. You will find that the report comes, they will give you a tracing where you find the wave pattern of the arteries. What are the different normal wave patterns in the artery? When you place the probe in the artery, you will find the normal tracing is what? The normal artery tracing is described as, you already said,
Triphasic.
triphasic. Good. So once you place the probe over the femoral, popliteal, posterior and then go down, normally this artery should show a signal which is triphasic.
Yes.
What is the reason for the first positive deflection?
Because of the systolic blood is going through the
Yes.
arteries and that
First
creating a
is the systole. Try to understand. Once there is a systole, that wave transmits to the arteries.
yes,
Why is the negative deflection?
because the arteries are recoiling and
That is diastole. So
right.
once there is diastole, the positive deflection goes to negative deflection. Why is the next small positive deflection?
Because there is ventricular filling and like that.
Then at the phase of end diastole, before the systole occurs, at the end diastole, the ventricle fills and that pushes the aortic valve towards the aorta. That creates a wave.
Yes.
So if on applying the Doppler probe, you can see that the pulse wave tracing is triphasic, that indicates that it's a normal wave transmitted through the arteries. There is no stenosis, no critical stenosis. Once ischemia occurs, when the artery gets stenosed, all these waves may not be transmitted to the peripheral arteries. So this wave pattern can change. This wave pattern can change to biphasic wave or it can be monophasic wave. So this pulse wave tracing can give an idea of the status of the blood vessels. Next is, once you place the probe over the artery, the blood flows into the artery with a velocity. As the heart
Yes.
contracts, this blood travels in the arteries with different velocities. So you can measure the blood flow velocity. You will
Okay.
find they gives a value. This meter per second.
Yes.
So this stenosis vessel, initially the velocity may increase, and then ultimately the velocity goes down once there is critical stenosis. So the next assessment by this duplex study is you can measure the blood flow velocity. So
Okay.
first thing you assess was sound. Second thing you assess was the pleural wave tracing, monophasic, triphasic or biphasic. And third thing you are assessing is the blood flow velocity.
Yes.
There is another thing you can do by using the Doppler. What is that? You can measure the blood pressure in the upper limb using a standard sphygmomanometer cuff.
Okay.
But using this normal stethoscope and the sphygmomanometer cuff, you cannot measure the blood pressure in the thigh. You cannot measure the blood pressure in the cuff or in the ankle. For this, you need special cuff and this Doppler probe.
Okay.
So using this duplex study, you can measure the segmental blood pressure in the limb.
Okay.
So applying the thigh cuff, you listen to the popliteal artery. This gives you a idea about the segmental blood pressure in the thigh. Measure the pressure in the cuff by applying the sphygmomanometer cuff in the cuff and listen to the posterior tibial artery. You can measure the pressure in the ankle.
Okay.
So why is this segmental pressure measurement important? How does it help you? If you have
So we
pressure
can
measurement
exactly
in the thigh,
localize
yes.
the compromise where the blood supply has compromised.
So what is the observation? If you measure the thigh blood pressure and the calf blood pressure, what is the normal variation? Thigh blood pressure will be little higher
Yes. Sir.
than the calf blood pressure.
Yes.
But these drops should not be more than 10 millimeter mercury.
Okay.
If it is more than 10 and more than 20, that is a significant drop. That means you measure the blood pressure in the thigh.
Yes.
If it is 130 and you find the calf blood pressure is 90, that means there is 40 drop.
Yes.
Drop of 40 is a significant drop, which might indicate there is a compromise of this next segment of the blood vessel. So you can measure the segmental blood pressure. And by measuring the arm blood pressure and the ankle blood pressure, you can measure the ratio. What is that called as?
Yes. Ankle brachial pressure index.
Yes. So ankle brachial pressure index is an important measurement which will help you to assess whether there is a disease in the lower limb vessels.
Yes.
What is the normal ABPI?
So 0.9.
It
Greater
should be
than
more than
0.9.
0.9.
Yes.
So if it is anything between 0.7 to 0.9, it will indicate there is mild ischemia.
Yes.
0.3 to 0.7 will indicate that it's a moderate ischemia. If ABPI is less than 0.3, that indicates critical ischemia. That is, the patient is may develop gangrene.
Yes.
So once you say something in the examination saying I'll do a duplex study, you should understand what all information you can have by doing a duplex study. So tell me again, what are the things you can assess by doing a duplex study?
So one is we can hear the sound.
Yes,
Then we'll
audible
know the
sound.
velocity.
Whether
Audible
you
sound.
listen to normal labdub sound or it is replaced by a rumbling sound
Rumbling
or
sound.
no sound.
Yes.
Next,
Then we'll understand the velocity.
blood flow velocity in the
Yes,
limbs,
sir.
in the vessel, in the
Yes, sir.
particular vessel. Third
Yes. Sir, the triphasic, monophasic, or biphasic
is,
waveform.
so you can have an assessment of the uh, pulse tracing.
Yes.
Normal pulse tracing, which is normal tracing is triphasic. In critical stenosis, this may be replaced by a biphasic or monophasic wave. And fourth is, you can measure
The segmental. That's
segmental blood pressure. So a drop of more than 20 is significant
yes.
drop of blood pressure, which might indicate the disease in that particular segment.
Yes.
And using this, we can assess the ABPI.
Yes.
So as I said, the patient with atherosclerotic vascular disease may involve the more proximal vessels. So do you need to do any other investigations? You have done a Doppler study. You find there is disease involving the femorals and the popliteals. So that is a disease involving the more proximal vessels.
Sir, angiography. Can you do?
What angiography? Now you have different ways to assess the vessels. It can be a non-invasive investigation also, like
Yes. Sir, subtraction digital angiography.
if you want to do digital angiography, you need to inject contrast in the vessels.
Contrast. Okay.
Now there are other ways you can do. If you want to do a non-invasive investigation, you can do
CT angiography, sir.
a MR angiography.
Okay.
In MR angiography, you don't need to inject any contrast,
Okay.
but you can do a digital subtle angiography by using contrast, because this can help you to assess the exact vessel segment where there is narrowing, and at the same time it can be therapeutic. Okay, in MRI you cannot do any therapeutic intervention.
Yes.
If you are doing a standard angiography, peripheral angiography, if you find there is a narrow segment of the vessel, what therapeutic intervention you can do?
Sir, angioplasty or
Yes. So now there are specific indications. There are specific indications of doing a peripheral angioplasty or endovascular treatment.
yes.
Okay, this patient already had a gangrene in the great toe.
Yes.
Now then you find that there is more proximal vascular disease. What are the indications for endovascular treatment? When you consider doing, because there are a number of ways that you can help the patient out of this ischemic disease. One is conservative. Second is endovascular treatment. Third is vascular
Sir,
bypass graft.
then, so autologous venous grafting thing.
Yes, venous grafting, or you can use some synthetic graft also.
Synthetic grafting.
So tell me, what are the situations that you can consider doing a endovascular treatment? Endovascular means you can do angioplasty, or you can put a stent also in the peripheral arteries.
Yes. Yes.
So in what condition you can consider this? You have done an angiography, and angiographic finding will guide you to do this sort of intervention. It's a balloon angioplasty, na?
Sir, there is only atherosclerotic changes, then
No, yes, atherosclerotic changes, but in what situation your angioplasty and stenting endovascular treatment will be helpful? Number one is, it should be a short segment disease.
obviously.
If you have a long segment atherosclerotic plaque, long segment disease, these are not amenable for the endovascular treatment.
Endovascular treatment. Okay.
So a short segment disease is amenable for your endovascular treatment, which
Okay.
can be angioplasty, and sometimes you can do peripheral arterial stenting also.
Mm.
This patient has got an aortoiliac disease. There is a disease, atherosclerosis disease involving the aorta and also the iliacs. And that is the reason that the femoral down, the supply is less. Patient has all the symptoms and signs of the peripheral arterial disease. So what can be done for these patients? You see, the result for bypass graft will be more effective in proximal disease or distal disease.
The proximal disease.
Yes, in distal disease, the bypass grafting may not be very effective because once you have a long segment disease, there has to be a distal runoff. That means once you find there is a long narrowing segment,
Mm.
there should be a vessel distal to this narrowing segment where you can do the bypass grafting.
Yes.
In more peripheral disease, this often is not possible.
Yes.
So the more proximal disease can be benefited by doing bypass grafting.
Yes.
How will you treat this gangrenous area? How to treat that? Because once you have a gangrenous area, that area, even if you do a revascularization, this area will
Yes.
not become viable.
Yes.
So how will you
Sir,
manage the gangrenous part of this leg?
sir, debridement and disarticulation will be done.
What is the principle? Once you have a
Yes.
gangrenous area, the principle is you should keep the area dry.
Okay.
You should keep the area dry
Yes.
and you wait for the demarcation to appear.
Okay.
So if you have done a endovascular treatment, these are the patients who can be benefited by conservative amputation.
Okay.
Okay, the idea of doing the endovascular treatment or bypass grafting is this patient has got a gangrene in the right great toe, but this is more proximal.
Yes.
So in that case, we are trying to improve the blood supply of the limb. And then once we have done that, we go for conservative amputation.
Okay.
What do you mean by dieback? Once you have done an amputation, there is an entity called dieback. What is dieback? Dieback means you have done a conservative amputation.
Okay, sir.
And if the vascularity of that area which have retained is not adequate, this area again will become black.
Yes, sir.
So your amputation stump you have created by doing the amputation, if this stump again become black, that is a situation that we call that as a dieback.
Okay, sir.
That dieback has happened means your vascularity of that area is not adequate.
Okay. Yes.
Okay.
Yes.
What are the general advice? When you have done such intervention, what are the general advice for these patients as you go for follow-up? Because atherosclerotic disease is a systemic disease.
Yes, sir.
So what is the general advice for such patients? It's a generalized disease. This can affect the opposite limb.
Sir,
This can affect the
yes, sir.
cardiac. This can affect
Yes,
the
sir.
cerebrovascular disease. So,
Yes.
so patients should have
So,
some lifestyle modification.
yes, sir. Lifestyle modification and look for any uh, other limb changes. Then, is there any
Yes.
chest pain occurring intermittently or not?
Yes. So
Do
the,
the
the, the
etiology.
patient should have good control of diabetes.
Yes.
If the patient has got lipid abnormalities, patient should be given statins.
Statins.
If you have done a bypass graft with a stent, you should give this patient uh, uh, some platelet uh, inhibiting drugs like aspirin or clopidogrel, and then patient should exercise to the limit.
Okay.
So these are the general advice you should give for a patient who has got peripheral vascular disease.
Okay.
So you see, ward round exam is hardly 5 minutes or maximum 10 minutes. But your approach is important. Once you
Yes.
have this card showing this patient as black discoloration, how will you proceed?
Yes.
So you should say that I'll take a good history, I'll examine the patient, I'll plan some relevant investigations, and based on the investigating findings, I will plan my treatment. So that is the
Yes.
approach for any problem scenario, any ward round scenario. That is what approach should be. Okay. Dr.
Okay.
Steiny, you are in which college?
Sir, Howrah District Hospital.
Okay. You are in second year.
No, sir. First year. Just joined.
Okay. Okay. Fine. Fine. Thank you. Thank you very much.
Okay, sir. Thank you, sir.
Any question? Any question?
No, sir.
Any question from anybody else? I am sorry that actually the link was generated too late.
No. Yes, sir. It's okay.
Okay. Dr. Bosa, would you like to add something?
Thing to add.
Bosa, unmute.
It is a good class. We enjoyed the class. But one thing I am thinking is you are asking the question, you are answering. The postgraduate trainees should tell these things. This is the.
No, she is first year. Try to understand. Dr. Bosa, she is first
Eh,
year. You first year. That's why
okay, okay.
I just kept on asking, and I tried to give the what should be the ideal answer for this situation. So these are the things should be faced by third year residents. So she is in fact
Uh,
first year.
uh, the,
So
this is happening in my KPC Medical College also. The first year students, those who are coming, they are not very equipped to handle the ward situation. I am finding this increasingly difficult because they go to the dams course, read the dams or whatever, and they are detaching themselves from the ward because this is a final MBBS standard long case, peripheral vascular disease.
yes, yes. But
Now,
as I said,
now,
now in a ward round, it will be hardly 5 or 10 minutes examination.
no, they
So
should they should they should concentrate more on the word things. That is my suggestion.
yes,
And they should concentrate more on the word things. One, they have entered into MS course. They should do this.
thank you.
Thank you.
Thank you, Dr.
Thank you for your
Thank you.
effort at this age, Makhanda. Thank you. I
Thank
always
you,
try
Dr.
to listen it because that reminds me most of the thing.
Thank you.
Thank you.
Thank you. Thank you.
Bye. Bye.
Thank you, sir.
Thank you.